All right, good afternoon and good evening, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, and I'll be your moderator. Dr. Sam Kratchman is our speaker, and he'll be reviewing the importance of 3D imaging in endodontics. If anyone has any questions, please feel free to drop them into the Q&A section, and we'll get to them at the end of the webinar. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand, and this webinar is sponsored by J. Marita. Dr. Kratchman, welcome back.
Adam, thank you so much. I appreciate the invitation, and hello, everybody. I can't see any faces, but I hope that whether you're on West Coast, Midwest, East Coast, you'll enjoy the presentation. I'm sure that most of the people listening are restorative dentists, so I will gear this presentation on cone beam to everybody, little tidbits for everybody, whether restorative or the various specialties, or of course to other endodontists. So with that said, let's begin the presentation. And the outline time, I'm going to talk to you for the next 45, 50 minutes, and then I'm here as long as you need me to answer any questions. We're going to get through this and show the various uses and benefits of the cone beam, and also try to show whether it's necessary or something that is now not just a state of the art, but perhaps becoming a standard of care, especially for the diagnosis of some of these issues like you see here, like resorption, cracked teeth, and so forth. Now, can this machine pay for itself? I mean, the machines are very expensive. I happen to have the J. Marita in 3 of my 4 offices. I love the clarity of it, and what little I know of technology, I'm very comfortable managing the software. I find it very intuitive. And I do not agree with the practice of just randomly taking a cone beam on every single patient. I know that it's potentially a good moneymaker, but really you have to have reason for it. And you can see here, this might be one of the records of my practice to do 9. This is just my schedule, doing 9 cone beams in one day. But typically I will take it for all surgical patients. I will take cone beams for the retreatment cases of endodontic failure. And then various other cases where I have something in mind, like I'm not going to take a cone beam for an anterior tooth that I know has 1 canal in the maxilla, and it's a standard type of root canal. So I feel pretty strongly about that because there is radiation to the patient, and the patients are very conscious of this. And I know that some people, just because insurance companies don't necessarily pay for these cone beams, so it's extra money for the doctor that the patient has to pay out of pocket, but there are definitely cases where it's necessary. Now, the one thing that some of the companies and all the cone beams claim is that, oh, you could easily see cracks on teeth. It's great for diagnosis, and it's not always true. So what you're looking at here is a comparison between an older Marita image on the left, both up top here and over here, and now the newer X800 that has some artifact reduction. And you have to be aware that whenever you're dealing with restored teeth, whether it's porcelain fused to metal crowns, whether it's a restoration, whether it's root canal, and you've got a perch in the canals, you're always going to have some scatter or noise. And a lot of times the way that these companies try to get around that is they degrade the image so that, yes, there's less noise, but then it's not as clear. I'm very impressed with this new X800 Marita. I just got that from my new office, and I am finding that some of these cases, as you would see the scatter over here coming off of gutta percha, actually is clearer, and you're able to see it's almost as clear as a periapical film. So I am very impressed with some of this new technology. And this kind of stuff drives me crazy because all the time I'm getting cone beams, I'm getting notes, I'm getting images from practices, whether it's oral surgery practices, perio practices, other restorative practices. I hate when a patient shows up and they have a CD of their scan with them. I'm scheduled for like a 20-minute evaluation appointment, and the note says, please evaluate teeth numbers 2, 4, 8, 12, 18, so forth. And I don't have time, nor am I familiar with all the different softwares. Yes, I know that you can put it into a type of software that, regardless of the brand, will help to pick it up. There's sometimes that it could take 10 minutes just to pull up a cone beam, and then I have to start manipulating it. I don't have time for that. So what I do, and I'll show you in the next couple slides, is I just cut and paste relevant images and I email them as a report to my referring dentist. I can't tell you how many times I get images like this that we see and notes that say, well, one canal can be traced apically, the canal is not visualized due to artifact, or you just see these images, and to me, this is worthless. I can't make out anything from it. And if a patient just recently had a cone beam, they don't want to be radiated again. Okay, so if you're going to take a cone beam, please just take the 5 minutes that it takes to be able to send a report. And this is typically what I do. This patient came to me with some pain around this second bicuspid area. It looks totally normal on a PA film. Took a cone beam, and sure enough, I could see that there is some bone loss here, right? And I'm trying to just point this out to the referring dentist. So all I do is I go to the middle of the screen, right click, say copy all images, and then I cut and paste it onto my desktop. And then I'll email this with the PA film, and I'll write a 1-sentence letter to the dentist saying, hey, look, there's some bone loss here, suggestive of possibly a crack or fracture. You can go over here where the arrow is. You can see the toolbar. From here, you can get these yellow arrows and just put it in an area that you want to point out to the dentist. And this literally takes me less than 2 minutes to generate this. And then I just have to place it into an email. And then if you want to, for example, decrease the size of the arrow, you right click on the arrow and you can decrease the size of that if you find this a little bit too obnoxious. But this is showing where the bone loss is. And on a PA film, it looks totally normal. But when you see this kind of a pattern of this angular defect, otherwise healthy dentition and healthy bone structure, then I can't say that there's a crack. I don't see a crack on any of these images, but you can say that the pattern of bone loss is suggestive of a crack on the tooth. And then if you want to elevate a flap or do some deep scaling or re-enter the tooth to see if anything is going on internally, you can. How about a case like this, where the radiograph presents like so, fairly well done root canal with a periapical lesion, a post floating in here. So it looks like they made a large post space and then put a cement, screw post. Immediately from looking at this, you'll say, oh, well, obviously I have to retreat this root canal. This post is just floating there. I want to go in and remove this gutta percha. Not that I'm going to instrument it that much wider, but I want to take care of this space, possible apical surgery in the future. And look at the cone beam, how you can see that this post is totally off axis with the direction of the tooth. And you can see here on a 3D rendering that it appears that it's perforating out the palatal aspect of the root. So if you just jump in and start doing a retreatment on a case like this, you can get stuck by saying, oh, wow, there was a perforation. And now you're kind of backstepping and talking to the patient. Say, oh, I didn't tell you this, but, I found out that there was this perforation there, which I didn't expect. Whereas by looking at this cone beam prior to starting the case, you can already tell that there's problems going on here. And a tooth like this, if it's perforated and it's a long-standing perforation, may have to be extracted, or we may have to do a repair of that perforation, but it greatly decreases the success rate. This patient came in to my private office. We were a bunch of things going on. We were looking, we couldn't really see the roots of number 14, which was the patient was scheduled for. We took this cone beam, and you can see here on the axial view, here's tooth number 12. 13 is tucked back on 14, and I'm looking to see the shape of this mesial buccal root on 14 to see whether there's a possibility of an MB2. So when you see a mesial buccal root that's shaped like this, like a kidney bean shape, typically there will be an MB2. So you have your guidance when you're going in. We often joke by calling the cone beam our GPS for preparing to do these cases. And then something is going on there. Looks like possibly an odontoma. But my favorite part looks like a little baby boy in the fetal position, right? That's why I have a baby boy with question mark. But what I want to point out is you look at not just the still image. This is not me right now. This is a video that I made. But if you look here, focus. So what I typically do is when I run through a cone beam, moving that green vertical line on the lower right, but I'm looking on the lower left. And right there, you can see that is actually a tooth, right? So it's a supinary tooth up in the sinus area. And on this one still image, it's a little tricky to see, but when you look at the various angles, you can see here's actually the enamel surface of the tooth. So the point is that you have to look at the whole scan, not just a still shot, even though I'll typically, send I'll cut and paste those 4 images, as I pointed out. This was a crazy case. Patient came in, tested the central, actually was vital, right? So the lateral incisor was the source of the lesion, but look at the angulation of this. And this was the most difficult part. So imagine this tooth is tucked back here, and I'm trying to angle my burr so that I can get into the canal space of the lateral incisor. Look at the axial view, how it's literally tucked behind, and I'm trying to gain my access so that I could get into the canal. So I needed this cone beam preoperatively to be able to see the direction that I was going to take for this access. And then I took later on a scan after I did the case so I could see the success and how I was able to find that canal. This patient came into the clinic at Penn, one of my former residents. We worked on this case together. And the treatment plan here was to intrude the 2 bicuspids, right? And then place an implant in this edentulous area where the lower first molar was. So in perio, they placed the TAD, and the TAD is going to be hooked to a wire that they're going to then intrude these bicuspids. So what happened apparently here is when they first placed the TAD, they weren't happy with the location, maybe a little too close to this root, or maybe it didn't give them enough access to be able to wire and pull down his teeth. So then they replaced the TAD here. 1 month later, they removed the TAD, and the patient is starting to experience some discomfort over here. Look what's happening here in that month since we started, where before the TAD was placed. Now, 18 months after the TAD was placed, the patient is starting to develop pain in this tooth. As an aside, this implant was placed 6 months after the TAD was placed. You could see how far down the occlusal is here. So that's why they're going to have to intrude these and possibly do endo here. But this is starting to cause symptoms. And now look at the scan, and you can see that when the TAD was removed and replaced, they actually nicked the side of this bicuspid. And when they place this TAD, they damage some of this PDL. And now there's a complete breakdown of the bone laterally, and it's starting to communicate with the sulcus. So this becomes very guarded prognosis, and the patient may end up losing this tooth now and having to graft this site and place a second implant. It's very dangerous when you have some infection brewing here right adjacent to the site of a recently placed implant. So in this case, the cone beam was very important in order to be able to see what's going on, and it could very well alter the treatment plan to require extraction of that tooth. This patient was seen by one of my partners, Dr. Eltom, phenomenal endodontist. Very, very difficult tooth. Bifurcated bicuspids. In this case, actually, it was trifurcated, but even bifurcated bicuspids, in my opinion, is one of the most difficult teeth to have root canal treatment done. Because what happens, if you look at the pre-op PA film, your file is going to follow the path of the larger canal, which is usually the lingual canal. Usually in a bifurcated case is a lingual and a buccal canal. And if you look at, this is an image from an old study in endodontics from Hess, literally back around the turn of the century, where they placed vulcanized rubber into extracted teeth. But if you look at the real tooth here, you hit a kind of a dead end here, and the file keeps on wanting to go into this canal. And Amir, my partner, suspected there were two canals. So he opened it up, instrumented, found two canals, placed calcium hydroxide. Then he took a cone beam, and what he found, and if you look at this axial view here that I'm circling, here are the two canals with calcium hydroxide. The body is very symmetrical. So when you have, and there's a lesion over here, by the way, the body is very symmetrical. So when you have two canals here and you have all this root space, there's got to be another canal here. So not only is this a bifurcated, but it's actually a trifurcated canal. And he had the patient come back and was able to locate that third canal. Very, very tricky tooth, because you have to create a glide path or straight line access to be able to get into each of these three canals. Then even after all that, you still have to figure out a way to obturate these cases. So you typically would have to place a cone in here, burn it to this level through a microscope so that you could visualize this canal, place a second cone, burn it to that level to make room for a third canal. So very, very difficult case that was very well handled. This patient came into my office with the following note from an oral surgeon. Patient was told that there is a huge cyst in the sinus from the first molar and would require a very difficult extraction with possibility of oral antral communication, then sinus lift, bone graft, and eventual implant. And the patient was very upset and very nervous. And the imaging that was taken was one of those full arch scans that honestly, it had no diagnostic ability to that scan. So I said to the surgeon, I said to the patient, you mind if I could just take my own scan and we'll be able to get a better look to see what's going on with that molar. Sure enough, when we take the scan, yes, it's a decent sized lesion. I measure it by about 7.9 by 5.5 at this level. So yes, it's getting a little bit on the larger side. When you get above 7 millimeters in diameter, according to a lot of the literature, may not heal spontaneously from just root canal treatment. I may have to go in surgically and clean that out, which I have no problem doing. But also, this shows on this view here that it's not even perforating into the sinus. So whereas we look at a PA film or this other full arch scan, it's hard to distinguish, and the surgeon is ready to extract it and sinus lift and all that. In reality, all we have to do is either retreat and or apical surgery and save the tooth very predictably, and probably even staying out of the sinus. So it's very important to do proper diagnosis before determining your treatment. This is very interesting. I just added this to my presentation because the patient just was in here in my office not too long ago. And the Patient had no symptoms, yet there was let me go back, but what looked like possibly a lesion that the referring dentist picked up. So if this is truly a lesion, then the tooth will be non-reactive to cold. And even with a crown on and calcified roots, sometimes you don't get a cold response, but sure enough, I got a cold response. So I said to the patient, let's take a cone beam and see what's going on here, because I agree with the dentist that I see what looks like radiolucency, maybe even here, but yet you're responding normally to cold. Now, yes, you could have what's called a partially necrotic tooth, meaning that the palatal root could be vital, but the buccal's not. And when you look here at the sagittal view, yes, it does look like there's a small lesion adjoining the ligament, but look here, this is the key. And I go into this a lot when I give lectures about surgery, is that this is the anatomy of this patient's distal root, where the root is actually sticking out of the bony envelope here. So if you were to raise a flap here on the buccal, you're basically staring at this root. And if you look here, I think this is the pattern of bone. The tooth is perfectly normal to cold, normal to percussion, palpation, everything. And I think that this is just the anatomy of this tooth. And I chose not to do any treatment. Later at the end of the lecture, you'll see cases like this where when I see the root preoperatively before surgery sticking out like this, and I know I'm going to cut off the end of the root, it's much more difficult to get bone to regenerate like this when the tooth is so close to or even sticking out of the window of bone. So very interesting diagnosis from this. This case came from Connie, one of my former students who practices in Germany, fantastic student. She's nice enough to share this case. She also has the Merida cone beam back home in Germany, where you have this dens and dente, which is the tooth within a tooth. And there's a lesion around the inner tooth here. So she did a beautiful job treating this, where she completed the endo. She used the 3D shaper and finisher, and then put total fill syringeable BC, which is the name of the bioceramic sealer over in Europe, and also known as root repair material. Then she put some fast set putty and some composite here and permanently restored it. In Germany, Connie is both a restorative dentist, but also very well trained in endo. And now she'll see whether this will heal, or she may have to go in eventually surgically to take off this outer shell, if you would, from the original tooth, and then have this dente within the dens as the final product there. This patient recently came into my office debating whether I'm going to do a retreat or apical surgery here. And the root canal was very well done. You see a sealer puff towards the frication here of this mesial root. You always wonder whether both MB1 and MB2 were treated. And in this case, when I take the scan, this is the coronal view of the mesial root. Very clearly, MB1 and MB2 were treated. Beautiful job done on the root canal. But if you look very closely where this yellow arrow is, right here is an apical split. This is very, very difficult to manage. There's no way that I could treat a canal like this and get a split, get my files to go out here. And you can see that the lesion is circling right around where that split is. So do I spend time to do a retreatment? Probably not being able to get to this, or what I chose to do is, and what I will do with the patient, because recently she just came in for the consult, is I'll go in surgically and I'll do an apicoectomy on this mesial root, cut off the root up to this level, and then place a root end filling material. Now, not every time the patient is referred for one procedure, but the cone beam sometimes dictates the treatment. So this patient was referred to me from another endodontist, an older gentleman who doesn't do apical surgery. He did the original root canal. and he refers to me for apical surgery. Well, here is the coronal view of the root. There was a missed MB2. So let's look at the shape of this root. And if I was to do an apicoectomy, I'm basically shaving off 3 millimeters of the root. That's our protocol when we're doing apicoectomy. If I shave off 3 millimeters of MB1, I'm barely touching MB2. So now I'm going to have to adjust that to get down another few millimeters on MB2. And then I'm at a negative bevel. So in order to visualize that, I'm going to have to flatten this out. And now I've affected the crown root ratio. So even though the patient was referred for apical surgery, I had to politely say that I'm going to choose to do a conservative retreatment, not a surgical retreatment of this case. And here's a different tooth, different patient, similar situation where I'm using my cone beam once again to kind of plot out what I'm going to do. Here is the mesial buccal root. MB1 is treated. MB2 is missed. The lesion is clearly around the missed MB2. Once again, in order to cut off about 3 millimeters of MB2, I'm going to have to take off about 6 millimeters of the MB1 root. And now the crown root ratio is going to be adversely affected. So cases like this, regardless of what the tooth is referred to me as, I have to do my own diagnosis, and I'm going to choose to do a retreatment in a situation like this. How about this patient? Referred to me to evaluate this upper canine. It's a 84-year-old patient, asymptomatic. Upper bicuspid, actually, very long bicuspid. I can see there's a molar there. So yes, I see what looks like this radiolucent lesion. Maybe it's a resorptive defect. Great, I could raise a flap, fix it, right? Look at this on the cone beam. The defect is eating away palatally. So we're looking at the palatal aspect of the root. That changes things. And also look at the extent of it. So in order to be able to get to something like this, I'd have to raise a palatal flap and clean this all out and then place some type of a restoration, like a glass ionomer, like a Jerry store type of material or biodentine type material, in order to hopefully prevent a deep pocket over there. So with all good intention, you can try to fix this, and then it could turn into a severe perio defect with deep probings. So patient is asymptomatic, 84 years old. I'm choosing to observe cases like this. I show this to the referring dentist. This is exactly what I cut and paste and send to the dentist. And I say, if this ever becomes symptomatic, meaning if this defect gets larger and starts to impinge on the pulp, then I could do the root canal, and I could always try to remove the defect and seal it. If not, we just observe, and with such a long root like this, hopefully patient could keep it for many more years. This situation was a little bit different because the defect on the palatal here was right at the cervical margin, the gingival margin. So I felt that I had an easier access here. You can look here, this lesion is right below the cervical part on the palate of this incisor. And here is the palatal bone. So I had easy access to get to this defect. I did the root canal because in cleaning out this defect, you have to be aggressive. You have to get to solid tooth structure. And you can see that it would be very, very close after curetting out this defect. So of course, I'm going to do the root canal first so that I could be as aggressive as I need to in order to clean the defect. And then I used the Jerry Store glass ionomer. And here is my pre-op, post-op, and a 2-year follow-up. And what you hope for with the glass ionomer is to get long junctional epithelial attachment and hopefully manage that you don't have such a deep probing. What's very interesting with these resorptive defects is that the pulp wants to protect itself, and it lays down some pre-dentin or tertiary dentin. And you see cases like this that I love looking at the cone beams here, because look at the pre-op, post, the periapical film. you could see something is going on here, but look at the extent of this. And the interesting thing is that you could still make out the pulp canal, the root canal. So the defect is coming in this way, going around here, going around here, going around here. You can see that it's surrounding the pulp, but the pulp is doing its best to try to protect itself from the insult of this resorption. Cases like this are hopeless in terms of you can't, first of all, if you try to do a root canal here, you're not going to be able to get to the end of the root a lot of times because you're going to get caught up in this defect. And this is a lot of bleeding tissue, very difficult to control the bleeding from this inflammatory resorptive defect, and tough to manage to get the files. Sometimes the files will perforate out the side because the tooth structure is so thin. And then if you try to remove the defect to restore it, you're going to end up just destroying the whole tooth. So cases like this, we hold on to. If we see bone loss, you get it extracted. If it becomes symptomatic, you get it extracted. Here is a long-standing case of resorption that actually arrested itself. So patient probably wasn't even aware of this. And this is the true definition of ankylosis, where there was resorption and it's long-standing enough that the part of the tooth that has been eaten away by the resorption is now replaced by bone. So you can see the bone is filling in almost to the level of the pulp chamber, replacing that resorptive defect. So this needs nothing. It's asymptomatic, and patient is not even aware of that this is going on here. And in fact, the tooth being ankylosed is pretty darn sturdy for the moment. This case I have to share with you because it's one of the strangest cases that I've ever witnessed. Patient came into my office with some missing teeth here and weird defect. First of all, the canine has a very strange buccal curvature like this. Usually the canine curves in the other direction. And he had this cervical defect here in the premolar number 12 and this resorptive defect. And I was asking the patient what happened to these teeth. And he said, I removed them. And I'm like, you mean you went to the dentist room? He said, no. He's like, I have this habit when I'm sitting around that I take a corner of a knife and I kind of like wedge it in between my teeth, like in the gum area. Patient had some mental issues, and he literally, his habit was to take like a butter knife type of knife and kind of wedge it into these corners. And he actually was able to flip out this teeth. He actually removed his own teeth with time. And on the ones that are remaining there, he's literally scraped away enough enamel to cause these defects. So of course I told him the obvious, keep the knives away from your mouth. But this is something that I was discussing with the restorative dentist. Then is he going to place implants there or something removable in case the patient continues to try to wedge out his own teeth, but never saw anything like this in the past and probably never will again. Now, can these cone beams alter treatment? And I've talked about this before, where sometimes the patients come in for one thing, but after the cone beam, I'll change my opinion. Cracked teeth are something that are so common, especially since COVID and recent presidential elections, which I never talk politics. So much stress. Everybody's grinding. They're clenching. And I've seen more cracked teeth in the last several years than I had in the previous 28 years of practice. Statistically, the mandibular molars are the most common teeth to fracture, followed by maxillary premolars. Very interesting because maxillary premolars have a very decent size occlusal surface, chewing surface, yet the roots taper. So we see so many of these maxillary premolars that have fractured. And as I said, oftentimes you're going to get scatter, especially when you have an endodontally treated teeth. And the rule of thumb is that if these lines, like the spoke of a wheel, go beyond the actual root itself, then these cannot be fractures, right? Because if it was a fracture, it would be confined to the root like so, okay? And it's very difficult and not predictable to be able to always see fractures. This particular case, patient comes in with this bicuspid, has a post placed, nicely done root canal, and I was actually able to probe about 7 millimeters on the palate, and I picked this line up coming right at the level of the post. So this is one of those rare cases that even with a metal post and the gutta percha, I was able to determine a fracture. And the benefit to the patient is that instead of putting them through a retreatment, surgery, all this kind of treatment, if I know that this is fractured and how guarded the prognosis is, we may be a little bit more aggressive and just say, look, I'm going to suggest having the tooth extracted before you start to lose too much bone, which would make for much more difficult implant. This patient came in, young boy, to the clinic at Penn. My Japanese resident, Dr. Kanami, saw the patient. Beautiful little kid. He's wrestling. He fell and sees this horizontal crack. If this crack is below the bone, which it is, then you do nothing, right? As long as there's no probings from the sulcus that go to this horizontal fracture, number one, this part of the tooth will remain vital. Number two, as long as patient can keep this clean and prevent bacteria from contaminating this area, then you'll get some kind of bony or connective tissue type of fusion here. And technically, you don't have to do anything. Then we took a cone beam. Look what this cone beam showed. This poor kid, not only was there that horizontal fracture, but it was a circumferential crack going all the way down around the tooth. So unfortunately, this little guy is going to have to lose this tooth and eventually get an implant when he's mature. Not easy to tell the mother of a 9-year-old that has to have the tooth taken out, but if you didn't take the cone beam and didn't see this crack and the extent of it and just kept an eye on things, then either would abscess or he'd start to lose a lot of bone, which would make for a much, much more difficult restorative procedure. This case, I used something called the cotton roll trick. And what you do is when you're doing an anterior cone beam like this, you stick a cotton roll under the patient's upper lip. And then what that does is it keeps the soft tissue out of the way right here and gives you a better view of this bony area. So you're not getting any distortion from the soft tissue. So I'm looking right here very closely, measured the lesion, and look at that right there. When I change the contrast here with that cotton roll and I expand it, actually can see a faint crack line going here. So once again, what might have been a long involved retreatment or an apical surgery now may be an extraction due to this location of the crack. Another technique is that we use, tooth sleuth or bite stick to determine whether a tooth has a crack. And we have a patient bite down on a stick and then release and see if it bothers the patient upon release. That means it could be indicative of a crack. So why not have the patient bite down on that bite stick while taking the cone beam? So the purpose is that if there is a crack, then as they're biting down on the stick, there's going to be separation or movement of that segment of the tooth, and you're actually able to pick up this crack. And you can see here, if you look at these yellow lines, it's actually able to pick up that fracture by the patient biting down on a stick while taking the cone beam. Another technique is the transillumination. We take a fiber optic light, shine it on either the buccal or the palatal aspect of the tooth. And if the light doesn't transmit to the other side, then that's another indication that there's a crack because there's deviation between the pieces here. So you won't be able to see it on the other side. And you don't always get this lucky, but patient came in to my clinic, my private office, lesion here, looks pretty innocent except maybe a periapical lesion, but look at, there's hardly any restoration, maybe little restoration. So practically virgin teeth, so no scatter from any teeth. And I was able to pick up this fracture line, crack line here. So instead of wasting the patient's time and money of initiating a root canal, patient gets sent to the surgeon for an extraction. Okay, let's move on to some more complicated issues. I'm going to be real quick here. We don't have too much more time. So I'll just touch base on each of these aspects because I was asked to talk about use of the cone beam for some of the more complex areas of endo. And this patient came in for diagnosis to my office. Unfortunately, in one of my offices, I don't have room for a cone beam. So I just took the PA film, said, very well done, root canal. I'll probably opt for apical surgery. But first I have to send you to my other office to have a cone beam taken. So patient goes to the other office, has the cone beam, and this is how I'm looking at the cone beam. So once again, this is a video, but as I'm scrolling with the blue line, I'm looking to the upper right, and yes, here is the mandibular canal and the mental, but as you scroll, look at how the nerve, boom, goes right back towards the mesial root of the tooth I was planning on doing surgery. So this is known as the anterior loop of the mental nerve. So here's the 3D rendering. So the foramen is exiting here, which is pretty darn close to the mesial root. But even worse than that, the nerve is coming through the mandibular canal out here and then looping back to right here. So I'd be afraid by doing apical surgery here, I could cause permanent damage. So I called the patient back and I said, remember I told you that I was going to do surgery? Well, change my mind. We're going to be doing instead we're going to be doing a conventional retreat because I'm afraid that I don't want to cause any kind of nerve damage to you. This patient came into the clinic at Penn, crazy situation here. Patient has paresthesia. Patient came from the UK. He was actually faculty in the business school at Penn when he came into our dental clinic. And he claims that he had surgery done in the UK and he's been numb ever since. So we took a cone beam and ready for this, patient has two mental foramina. These are the patient's two mental foramen or foramina, and that is normal anatomy. The surgeon in the UK flapped it back, saw the mental nerve coming out of the bone looking like granulation tissue, figured, well, this is the mental, so this has to be granulation tissue, and proceeded to cut the end of the root and sever the nerve, therefore causing paresthesia. And you could see here that the root was beveled, meaning that the surgeon in the UK actually cut that root and basically cut out the mental nerve, thinking that it was granulation tissue. And the poor patient's not going to regain sensation in that area. Let's move on to the sinus. I'm sorry that I'm going to be getting a little quick here because I only want to speak for another maybe 7 to 10 minutes, and then I'm going to then entertain questions. Patient of Dr. Coley's, my dear colleague at Penn, she did the root canal, 4 canals, upper molar, beautiful root canal. Patient comes back 6 months later in pain. She takes a cone beam, and that's that same apical split that I talked about. She did MB1, MB2, but look at that apical split. There's no way I'm going to be able to get to that. And look at the mucous side. Look at the thickening of this sinus, probably as a result of the infection going on around this tooth. Now, the problem with second molars is that they're too far to reach to do surgery. So what we do is an extraction replantation. We do a ton of them, and it's one of my very favorite topics. And if you ever decide to invite me back, Adam, I'll do a whole hour just on tensional replantation. So you remove the tooth, cut off the end of that root. Now you're getting to that apical split. So there's MB1, there's that apical split. So you've cut off enough that MB2 is gone. There's the distal, there's the palatal. Do all your work outside the mouth, replant the tooth. It adheres without even splinting. And now here's a 1-year follow-up. You can see complete bone fill, but this is the best part. Not only at 1 year did the bone fill in compared to here, but look at the sinus on the pre-op, and now look at the sinus. This is a normal looking sinus, maybe a tiny thickening of the membrane compared to a sinus filled with mucus as a result of this. So not only did the bone heal, but also the infection in the sinus healed as well. Next up, we're going to talk about palatal anatomy. As I said, these were all requests of mine, of me for this presentation. And if you're doing work on the palatal surgically, you have to be very conscious of the palatine foramen. That's where the nerve bundle comes out of. And it's going to be at the border of the hard and soft palate right around the second molar area. So I don't do second molar palatal surgeries. I would opt for an extraction replant, as I mentioned. But if you're doing surgery on the first molar palatally, then just never, you can go back into the soft tissue here, but never do a vertical here where you could possibly sever that palatine artery. And none of us want that to happen, or else the blood will be squirting out of the mouth. Okay. What's nice is now we have what we're doing a lot of at Penn is this piezotome. Instead of using a burr that's very difficult to reach back there, we're using a piezotome to get back, and we could actually do a buccal approach to the palatal root. So follow me here. This is very cool. Patient came into our clinic with my resident, Joe, and we treatment plan this together. And yes, he's going to first retreat these buccals, but when you look at the cone beam, the buccal roots are fused, and there's a very long isthmus here and a huge lesion. So we're going to be a little bit more aggressive. Maybe in private practice, I'll do the retreat first and wait. The residents, Joe will be graduating in a couple months. He's a phenomenal surgeon. So we decided that we're going to retreat and then go right to surgery. Now, this is the problem, because when you're looking from the buccal here to get to the palatal root to do surgery, that's 15.5 millimeters. That's pretty far in. In your favor is the fact that there is a lesion that you could look at, but this is pretty far in. So our bone cutting burr that we use for surgery only has 8.5 millimeters of cutting surface. That's too short to cut the palatal root. But now we have this piezotome that you can go from the buccal, and you actually could see the surface of it. So we're going to go real quickly through this procedure. We open up the bone, and what you'll see here, so we're cleaning out the granulation tissue. And now, just want to go fast. Clean out a granulation tissue, yummy. There's the palatal root that you could see from the buccal approach. So now we take this piezotome, and it looks like it's called the bone saw, and you have a perfect view here, your perfect visualization, because you have that long shank, and you're able to now from the buccal go all the way through and cut the apex of that palatal root. Scoop that out, and now after that we stain with methylene blue. There's the buccal and the palatal. Now we're going to prepare with ultrasonics, use the bioceramic putty, and this will give you a good view because the putty is white. Look at that isthmus. There's no way retreating a fused root like that you can be able to get in, even with the 3D shapers, even with this Sonendo and gentle wave and all that. Very, very difficult to clean an isthmus like that. And that's why we opted to go in surgically and clean it. And that's just a bone grafting material. There is the final of the palatal, the final of the buccal, and here is the final of all the roots. And the beauty of this piezotome is that you're able to see the whole cutting surface of it due to the angle and how long the shank is, as compared to the high speed when you're trying to drill and you're being blocked by that. Okay, so that's very important to note. One last case I'll show, and then I'll be ready to open everything up for questions. is another situation, this case, a lower molar, where we've developed this technique, and we've been doing a lot of this at Penn, of doing a bone window here. Instead of cutting a big hole and doing a big osteotomy, we're actually doing a bone window technique, and I'll describe that to you. And we use this cone beam to make all our measurements. And we're going to make a rectangular or slightly trapezoidal piece of bone. We're going to cut that window, pop that out, preserve it in a Hanks balance solution, and then place it back in when we're done. And that bone will caulk it with some grafting material and hope that that reintegrates with the bone and healing takes place. The ideal angle of this bone window is almost parallel, although you can do it trapezoidal like this and flaring out, but don't angle the window like this, because then you won't be able to pop it back in, and you'll see what I'm talking about. So we do all our measurements based on the cone beam. This is a lesion higher up in the furca, towards the furca area, but this is the bone saw from the piezo making this window. And now you see it making a little bit angled out so that it will pop back in. So a little bit of a trapezoidal type of shape. And now we pop that out. And while we're doing the rest of the work, we're going to keep that bone window in a Hanks balance solution to preserve it. Now we're scooping out all the granulation tissue. Now we're using that piezo to once again cut the ends of the roots with full visualization there, like so. Very easy, and it cuts very, very smoothly. Drying it, methylene blue dye, so we could see the ends of the roots, make sure that there's no cracks or fractures. Prepared with ultrasonics, bioceramic putty. And now we're going to put some autograft bone graft in there, an allograft of bone. Now this is neat. We're going to place the window back in, and we're going to use some collagen, kind of like caulking around the window or a door to wedge that so that it stays nicely placed. And that was a bone graft of O6 Plus, which is a cross-linked collagen membrane. So when we go to put the bone window back in place, first there's bone grafting in there. Then we caulk it with that foundation, which is a collagen graft material, also sold by Merita, by the way, through Shine. And then we place a membrane on top. Here is his final and 1 year follow-up. And the biopsy came back radicular cyst. And what that shows you is that it would not have healed just from doing conservative retreatment, because when you have a cystic lesion, you need to physically go in and remove that sac. And then, of course, with cone beam, the best is to look at follow-ups. So we have the pre-op here on the left, and on the right, we have the 1 year follow-up of both the roots. And if you could kind of make out the outline of where that bone window was, but you could see that it's integrating nicely and becoming part of the bone. So with that, everybody, I want to thank you so much for your attention. When I'm not busy with my head in people's mouths doing root canals, I'm a professional bartender. This is the bar at my house, actually right off of my kitchen. And the best thing about it is it never closes because it's in my house. So if any of you find your way to Philadelphia, or if any of you in the audience live in Philadelphia, you're always welcome. And I'll mix you any one of your favorite drinks, I promise. Thank you very much. And here is our website. And now I'm ready to entertain any questions. Thank you.
I totally forgot about your bar in your basement. That's so cool.
There you go.
I remember seeing that last year. I was like, that is such a cool.
Yeah.
All right. We do have a couple questions here. Let's jump right in.
Sorry if I went a little bit long here, Adam.
Nope, you're good. Do you always have to cut off 6 millimeters for apical?
No. I cut off 3 millimeters. I'm sorry. The point is that the protocol is to shave off 3 millimeters and then prepare 3 more millimeters with ultrasonics, what I was pointing out there is that if I cut off 3 millimeters of the mesial buccal 1, I was just touching the mesial buccal 2 due to the anatomy of that root. So in order to cut off the 3 millimeters of the mesial buccal 2, I would inadvertently have to cut off 6 millimeters of the MB1. And I did not want to do that because then that would affect the crown root ratio.
Is there software that allows you to map the complexity of the canal anatomy of a tooth?
I'm not an expert on the software. I'm not a computer geek. Like, I know the little bit that I know, and I'm good at that, those very few things that I showed. But that is definitely something. I'm very close with a Bruno Azevedo, who I believe you know very well, Adam, and he is a dental radiologist specializing in the Merida. And if there's anything on that Merida software, Bruno would know it. He's down in Louisville, Kentucky.
Okay, so this person is wondering, so you literally extract the tooth, do the root canal outside of the mouth, and place it back into the socket. Is that correct?
Yes, that is. And as I said, I have an entire presentation on them. I've done tons of them. The literature states about an 88% success rate. There's a lot of stuff that obviously I didn't have time to go into in terms of the technique, but the tooth has had a root canal done already and a retreatment, and this is the last ditch effort without extracting and throwing the tooth out. So, and I talk about this, I just gave this presentation yesterday at Penn. There are techniques of taking the tooth out atraumatically without breaking it, and then once it's out, you're keeping the root bathed in a Hengst balance solution similar to that bone window, which maintains the periodontal ligament for up to 30 minutes. And then just with a high speed, you're preparing the end of the root. I'm placing a bioceramic putty, and then I'm putting the tooth back in the mouth. And less than 20% of the time, you have to splint it, because if you take it out gentle enough by expanding the plates of bone, place it back in, compress the bone manually, have the patient biting down on gauze. I check the mobility 10 minutes later after going over post-op, and there's usually less than +1 mobility. So you don't even have to splint it. If you do have to splint it, you could put some sutures over the occlusal surface, passively holding it down, or I have a fiberglass material like a rope that I could use to splint it if there's greater than +2 mobility.
Would you typically treat a molar with external invasive resorption if the patient is asymptomatic?
No, it's all really based on the cone beam. Like, I would say I spent a decent amount of time in the lecture on that because that's how important it is. The cone beam really dictates the extent of the resorption, and equal of importance is the location of it. Like that first case that I showed with the very long bicuspid, you could be very fooled to think it's on the buccal of the root, and you can't probe it, you don't know. Cone beam shows that it's palatal. That makes it more difficult to get to. Sometimes the resorption is between the roots, right? I mean, it's on the root, but it's between the teeth. And you can't get to that surgically without destroying a lot of bone and possibly even damaging the adjacent tooth to try to reach it. So the best part about the cone beam with these resorptive defects is mapping out the location and the extent, and then you have an idea, is it even feasible to approach it? And more often than not, the tooth is pretty much just in a watch and wait mode. And if it becomes symptomatic, or if the patient bites into something and breaks it off, then it becomes an extraction and implant. If the patient's losing cervical bone, you got to be a little bit more aggressive, because you have to think about restoring that site if they lose that tooth. So sometimes you have to be a little more aggressive and say, hey, look, this isn't going well. I don't want to have a periodontal defect there. I want to be able to place an implant successfully. And those are cases you might have to pull the trigger a little sooner.
Is the piezotome cordless?
No, it is, it plugs into a unit, looks like an ultrasonic unit that you would have in a perio office or when you were getting your teeth cleaned, and there is a water bag, a bag looks like a saline bag, and the handpiece itself is connected by a cord, and there also the water port runs through that as well. And then there is a Bluetooth pedal, so you step on a pedal similar to a rheostat, but as far as I know, all the PAs, those that I've used, have cords.
Okie doke. Let's keep going. What % of fractures can you pick up on a cone beam?
Good question. I would say way less than 10%. And once again, it's dependent on the amount of restored teeth that there are. So for elderly patients with restorations, crowns, root canals, chances are pretty slim. A lot of those cases I showed, I felt like I got a little bit lucky and tried to give you some tips between a cotton roll in the anterior or the bite stick. But if it's a young kid without a lot of restorations, or that one adult case where the patient literally had 3-4 teeth that are virgin teeth next to each other, other than that, it's pretty difficult pick it up on a cone beam. Oftentimes, if you see it on the cone beam, you could see it in the mouth, meaning the tooth is almost broken in half, and you don't even need a cone beam. You just go right to the surgeon.
Oh, let's see. We've got so many questions in so
No
little
problem.
time.
I'll answer quickly.
Is there CBCT software that permits 3D overlay mapping of lesions to measure for healing over time?
That's great. Actually, I have a couple slides. Once again, my dear friend Bruno developed this software, and I'm not sure if it's marketed yet. And you actually can superimpose the old cone beam on top of the new cone beam and see exactly, frame for frame, if it's truly healing. That's a very important question, very technical, because if you play around enough with these, just like looking at x-rays, different angles, you could, get a false sense, oh, look how great this is healing. But you have to really go frame for frame and try to get the exact same angle and superimpose. Now, I'll tell you one thing. One of the benefits with the Merida is that you take a Scout Panorex of all your cone beams. So first you have a Panorex, and from that Panorex, the machine calibrates based on the tooth that you're doing. So if you have that same machine and that same patient comes back a year later or 2 years later, you can go back to their Panorex and then take the second cone beam off of that first Panorex. And that's a very nice way to try to reproduce the same angle and location of a second cone beam. But you need to have some sophisticated software, which I believe is in the making.
All right, we've got a question about guided endo. I don't know if that's going to be a complex question or not. If it is, I can have you answer it after the fact. Otherwise, if not,
I probably have to answer it. It's basically using stents and using digital impressions to create a stent, so that it's called targeted endomicrosurgery, and you can use it on palatal roots. You could use it on lower molars or on bicuspids. But that's very advanced. There's a lot that goes into, and you need to have a good lab and a good facility to be able to create those stents. But you need a cone beam in order to create it. So I'm happy to have a discussion with whoever's asking that, but let's do it via email.
Sounds good. I will pass that one on to you tomorrow. Let's do a couple more here. How long can the tooth be out for the transplantation to be successful?
So it only takes me about 5 to 7 minutes to do the work outside the mouth, because you're staring right at the tooth. The good news is that the Hank's balance keeps the periodontal ligament alive for 30 minutes. Generally, because I'm pausing to take pictures and videotape it, I probably have the tooth out on average about 10 or 12 minutes, but it's no rush at all because the Hank's balance keeps the PDL viable for 30 minutes.
Okey doke. Do you ever do selective endo to stop the resorptive extension damage? And second part, how often does resorption self-stop?
Okay. In terms of self-arresting, that's hard to say because you don't really know. I get lucky sometimes and I see the case like with the ankylosis. First question I could answer more easily, very rarely, believe it or not, does the resorption invade the pulp. You saw those cases where it circles around the pulp, but the pulp wants to protect itself by laying down predentin. So to be honest, there's a very thin layer protecting the pulp from the resorption almost every single time. And the resorption is external. It's an external defect. Internal resorption is a whole nother ballgame. The canal's ballooning out. So really, the only two reasons why you would need to do the root canal is if the resorption is getting so close to the pulp that the pulp becomes either symptomatic and live and pulpitis, or if bacteria infiltrates and it gets necrotic, then of course you have to do the endo. Sometimes I'm doing selective endo if, like that case where the resorption was right below the gum line on the palate of that central incisor, I knew I wanted to be aggressive in cleaning out the defect. Last thing I want to do is clean out the defect, perforate through that thin shell into the nerve, and then say, whoops, now I got to stop and do the root canal. So in those cases, I'll do the root canal prophylactically prior to raising a flap and removing the defect. But these are external defects, and technically, they very rarely invade the pulp, very small percentage of the time.
All right. Do you mind if I share your email address with everyone, or would you
course.
prefer not to? Okay.
No, fine.
I'm putting Dr. Kratchman's email in the chat for everyone. And let's see.
It is my private email, but it's okay. I'll get to him and read them. No problem.
Might be getting a lot of at-home bar service requests.
That I'm always happy.
Let's see, a couple more here. Any good hands-on CBCT courses you would recommend?
There are two. I hate to keep on talking about my buddy Bruno. I'm giving him free advertising. Bruno is called the Endo Guy, GUI, and he has courses down in Louisville. And then there's also Marty Levin, who is a little bit closer. He's out of Washington, D.C. area, Chevy Chase, Maryland, and he's always advertising, and he's a dear friend and fantastic. And his studies have done like volumetric measurements of lesions with these cone beams. So those are two courses that I could think of off the top of my head.
All right. I apologize if I mispronounce this, but I'll give it my best shot.
Sure.
Does radix entomolaris
Yep.
show radiolucency in the bitrifurcation region on the PA film?
So a radix entomolaris is an extra root that comes off. It's usually on lower molars, and it's very, very tricky because it comes off at an acute angle, and it usually goes very far lingually, like almost up against the lingual bone. And when you're doing a conservative treatment, you have to look outside your normal box that you would when you're doing an access to try to find this. Now, the cone beam, and I had some case, I just don't have time to show everything. The cone beam is a must when it comes to these cases with the radix, because you could flip the tooth around on the CAT scan and look to see exactly where that is coming off of. And then you can look at the axial view, meaning slices going down, to see where in the axis of that tooth you have to look for the entrance to that radix. So that's by far one of those rare cases that a cone beam, highly suggestive, not mandatory, prior to trying to tackle one of those.
All right, final question here. I know you use the Merita cone beam. There's a question that says, what make and model would you recommend and why? So
I like them all. To be honest, I have 3 of them, and each time when I've gotten a new one, the slightly different models come out. The newest one is the X800. And as I showed you, it is clear and great contrast, but I'm not going to lie to you. I even would take last year's model. It's if you can get good prices on some of the other models, I just like the machine. I mean, I've compared so many different brands, and you know, I'm not a paid consultant or anything for Merida. I've been using it for many years, and that's what we have at University of Pennsylvania. Question is, sometimes when new models come out, as with iPhones and sneakers, they don't make the older models anymore. So I think my first one is called the 3DE. Then I have the F40. Now I have the X800. So, and I think there's a model called the R100 or something. The best thing is just do like a comparison and see what's available. And they're happy to come out and, you know, give you demos or let you play around with them.
Excellent. Well, that'll do it. Thank you so much, Dr. Kratchman. Fantastic lecture as always. Thank you to Jay Merida for sponsoring tonight. If anyone does want to get in touch with Dr. Kratchman, I did post his email in the chat, or you can email us webinars@henryschein.com, and I'll be more than happy to connect you with him. We did record tonight, so we'll get that out to you in the next week or so. And then if you'd like to attend future webinars, visit henryscheindental.com/webinars for our schedule. Thanks everyone for sticking around late. Thank you, Dr. Kratchman. Have a great night.
Thank you, guys. Take care.